Welcome everyone. Today we want to talk about osteoporosis. Osteoporosis is the most common bone disease affecting 1 in 3 women 50 years or older, and in fact by age 70 it affects 1 in 2 women. Primary concern with osteoporosis is that it is a major cause of spine and hip fractures, which are often very disabling. Key point here is that osteoporosis has its beginnings in middle age. Adults reach maximum bone density approximately about age 35. After that, bone density declines 1 to 2% per year. This decline results in a loss of 10 to 20% of bone density by age 55 years. Often at that point, someone is either osteopenic, which is a light form of osteoporosis, or fully osteoporotic. Further bone loss accelerates after age 55 years to 3 to 5% a year, so it really begins to take off in the 50s. Bone is constantly remodeling, repairing areas of wear and tear related microcracks. 10% of bone is remodeled each year, with the entire skeleton being replaced every decade. This is a picture in those circled areas of a couple microcracks. And if those aren't repaired and they become more extensive in the bone, they weaken the bone itself. So those have to constantly be repaired. Remodeling is done by 2 primary types of bone cells: osteoclasts, which remove worn bone, and then osteoblasts that fill new bone back in. Up until age 35, these cells are in balance and there's no net bone loss occurring. After 35 to 40 years of age, osteoclasts become more active while osteoblasts become less active. This results in gradual bone loss. This bone loss accelerates between age 50 and 55 years, the result of hormone decline. Hormone is particularly estrogen, helps to limit the activity of osteoclasts, keep them appropriate, and stimulate osteoblasts. And when we lose it, all of that becomes out of balance. Osteoporosis medications work by either inhibiting osteoclastic bone removal or stimulating osteoblastic bone building. Ideally, an optimal treatment should do both. Osteoporosis medications such as bisphosphonates and then another class of medication like Prolia reduce osteoclastic bone removal, limiting remodeling of these microcracks. With extended use, they may cause the bone to become more brittle, resulting in complications such as osteonecrosis of the jaw. Another important complication associated with bisphosphonate treatment, like Fosamax, is transverse fractures, and these typically occur in the femur, the upper bone in the leg, and sometimes in the tibia, the lower bone in the leg. One of these transverse fractures is shown over here at the left, where the red arrow is pointing. These atypical fractures only occur in about 1.8 persons per 100,000 users per year. So for every approximately 115,000 users in a year's time, we're going to have 2 of these atypical fractures occur. They dramatically increase to 113 per 100,000 users after 8 to 9 years. This is thought to be the result of them inhibiting bone remodeling, not repairing the microcracks. So while in the beginning it slows the osteoclasts, taking bone away, which can be helpful, it eventually allows a different type of damage and brittleness in the bone to occur because of the arrest of remodeling. More recently, non-drug treatments have been shown to be effective in improving bone density, reducing fracture risks. Pulse electromagnetic therapy, or PEMF as it is called, is proven to be the most effective non-drug treatment. PEMF is unique in that it inhibits osteoclastic bone removal. It slows the osteoclast and increases osteoblastic bone repair. PEMF works using a pulsed electromagnetic signal that activates receptors on osteoblasts and osteoclasts, normalizing bone remodeling. Osteoblasts only work one bone remodeling cycle. At that point, they turn into what are called bone lining cells, which don't create further bone, or they die off. Each remodeling cycle, new osteoblasts must be replenished by stem cells, which come from bone marrow. This is a schematic on the left side of the diagram. The red, you can see an osteoclast which begins to eat out the bone in these areas that need to be remodeled. It's quickly followed by osteoblasts, the blue ones over more to the right side, filling bone back in. These osteoblasts, because they have to be repopulated each remodeling cycle, have to be originate from mesenchymal stem cells in bone marrow. And PEMF has been shown to activate a receptor on mesenchymal stem cells and their next generation, which are called pre-osteoblasts, activating their activity in population. You can see that pattern here, the mesenchymal stem cells going to pre-osteoblasts and then filling in the osteoblasts. PEMF, as I mentioned, activates a receptor on stem cells, triggering their conversion to osteoblasts. PEMF also activates a receptor called an adenosine receptor on osteoclasts, slowing their activity, not stopping it, not excessively slowing it, just slowing it where it's not going to be removing too much bone. This is a graphic representation. If you look in the upper right, it's showing someone age, an adult, 35 or under, the osteoclast activity represented by the red bar and the osteoblastic activity, the fill-in or the repair cells by the yellow-orange bar. They're pretty much in balance at that point. After age 35, the middle diagram you can see between age 35 and 50, gradual negative balance occurs with the osteoclast outperforming, being more active than the osteoblast. This is what creates that 1 to 2% slow bone removal in that immediate period. On the bottom right, you can see what happens after age 50, 55, somewhere in that range. The osteoclasts have become more active and the osteoblasts less, creating a significant negative bone balance. And this is where we begin to lose 3 to 5% of our bone mass every year after that. The purpose of PEMF is to balance those cells and take the bottom right activity and move it back more towards the balanced bone behavior, which it seems to do, according to the research and my experience with it, pretty effectively. This is our PEMF table. Those two hoops are magnetic solenoids. They're on a set of runners under the table, and they can encircle both the hips and the spine, which are the two primary concern areas. And once the patient is on the table, we slide those up, put them in position. It's about a 30-minute session that patients have to undergo a series of these to restore normal function. If you'd like to know more about bone health and your non-drug treatment options, we'd be happy to talk to you. We offer a complimentary consultation about this type of treatment. All you need to do is call the office 757-456-5053 and get a time to come in for a complimentary consultation. No obligation, just a discussion to see if this would be appropriate and if you'd be interested in it. So thanks for listening. I appreciate your time and have a good day.